Good morning, good afternoon, and good evening. Thank you for joining us today for an exciting discussion on sustainable introduction, integration, and scale of TB innovations. My name is Dr. Kimberly Green, and I'm the Global Director for Primary Healthcare at PATH, which operates at the nexus of people-centered care and introduction of new and high-impact products, such as those for TB. I'll be facilitating our dynamic discussion on what it will take to ensure more urgent access to truly transformative products that are just recently or soon to be available, including new low-cost point-of-care tongue swab collection and diagnosis for TB, as well as a promising suite of new and highly efficacious vaccines for TB. So we'll start first with going over a few logistics. We very much want to hear from you during this conversation, so please share your questions and comments with us by submitting them in the chat or Q&A box at any time during the webinar. Some of our speakers will be here throughout. Some will need to leave a little bit early, and I'll flag who they are so you know when you'll need to post a question if you have one. So please note this call is being recorded, and we will share the recording for all of those who were unable to join. We have a very rich and experienced group of speakers and panelists with us today. And I'll introduce them in just a moment. So let's go to the next slide. And next slide, please. So really the framing for this session is that there has been certainly progress in TB over the last decade plus, and certainly there is significant promise to meet the 2030 targets. But we know that there are tremendous headwinds, challenges that stand in the way of all of the work that needs to be done to accelerate TB prevention, diagnosis, and treatment. We know that although there are these phenomenally exciting tools that are available or soon to be available, we're up against an average time of introduction of new products in low and middle income countries that ranges between 5 and 8 years. So part of the question to this panel and as part of this webinar is this: how does this get radically shortened? How do we change this? How can we've asked this question a number of times. How do we use what was applied during the COVID response to ensure that there's more urgency in ensuring these truly transformative products are reaching the people that urgently need them as soon as possible? We also have an immediate opportunity with a lot of the reforms that are happening across the world in investments in true integrated primary health care. But at the same time as these transformative products across diagnosis, prevention, treatment are made available, how do we make sure that these products are part of primary healthcare packages? They're part of domestic financing so that they can be widely made available. So these are some of the key questions that our speakers and panelists will be responding to as part of this webinar. So let's go to the next slide. So the structure today is we'll start first with a scene setter, the state of the TB epidemic and product introductions in the pipeline. So we'll be hearing from Dennis Falzon from the World Health Organization. After that, we'll have some spotlights that are looking at the science, that are looking at models of people-centered introduction of new products and approaches. So we'll hear from David Boyle from PATH on the need for improved access to high-quality, low-cost TB diagnostics. We'll hear from Dr. Yulia Dudko from the Chernihiv Regional Hospital in Ukraine on decentralizing access to TB services through introduction of diagnostic and digital innovations, and from Fred Ambati from the Nyamira county government on strengthening integrated community-driven TB prevention and care in Nyamira County in Kenya. Then we will turn to a panel discussion where we will hear from Blessina Kumar, Farzana Muhib, Fred Ambati again, thank you, and Dr. Madhukar. And we'll end with a call to action from Blessina. So introductions for each speaker will come as we progress through the webinar. So let's now turn to our first speaker, to Dr. Dennis Falzon. So Dr. Dennis is the team lead for TB prevention and treatment at WHO. He has extensive experience, decades of experience across the TB cascade, and particularly in innovations, including in digital technologies. And he'll be presenting on some of the really exciting products that are in the pipeline or have already been made available. So over to you, Dennis. Thank you.
Thank you very much, Kim, and thanks everyone. Greetings from Geneva to all, and gives me great pleasure to be here to open this session. So my my presentation is on two things, right? So we want to have the first part, which is on the state of the epidemic, and the second part on innovation. So there'll be a bit of a whistle-stop tour because I only have 10 minutes. So you can go to the next slide, which just presents a snapshot of the state of the epidemic in the world. So we know that about a quarter of the world's population has been infected with TB bacilli. So not all of them would have remained infected, of course, but it's still a huge pool of people from amongst whom we get the incidence figures that you see here, about 11 million people falling ill with TB every year, and about 1.2 million who die of TB, making TB once more the most important single infectious cause of death in the world. We have about 400,000 cases of MDR-TB, multi-drug resistant or rifampicin-resistant TB, which complicates treatment, and about 600,000 people with TB HIV. The good news, as you see with these down arrows, which has been shown now, is that these figures are all going downwards, albeit they're going downwards slowly. This trace shows, yes, you can go to the next slide. This trace shows the incidence of TB on the top blue line. You can see it going down and it crept up again during COVID, and now it's going down again. Then the line in black is the people who we actually have reported to WHO as being found with TB and placed on treatment. You see also a dip during COVID, but now has been increasing. And this is one of the very good news of the latest years, that we have a narrowing of this gap. And also people living with HIV who have TB are also decreasing in incidence. Next slide, please. Next slide. Okay. So in terms of targets, so we have the three big global targets. You can go to the previous slide, please, which show the ranges in incidence, in deaths, and in those who are suffering from catastrophic costs due to TB. And as you see, the targets are still very far away. This is the endpoint at 2024. So we have one more year to get to the milestone of 2025, but still we will not achieve these milestones of 2025. Again, catastrophic cost still represents about one half of the households who are affected by TB, where we should have been about 0% at this point in time. Next slide, please. And the other targets are showing those which had been set by the United Nations high-level meeting of countries, which met in 2023, and these are the targets to be achieved by 2027. And you see that we are also not very close to where we wanted to be 3 years ago. Next slide, please. Okay, so we go now to the next part, which is on innovation. So this is very quickly during the session today. I think you will have more time to look at some of these aspects in a bit more detail. So this is the innovations on TB vaccines. So these are new approaches to TB vaccines. We're not talking here about the BCG vaccine, which has been with us for very long, but I think it's an encouraging pipeline of about 18 products, 6 of which are now in phase 3, and we have a few of them that are advancing, and we hope to give us some good news in a couple of years' time. So these are particularly the M72 and MTB-VAC. Next slide, please, which shows some of the efficacy that was observed during the phase 2B trial of the M72 trial, which showed an efficacy of about 0.5% or about 50% reduction in risk for TB, which is quite substantial. Of course, it's not in the area of where we're used for childhood vaccines, but still, if this level of efficacy is confirmed by the phase 3 trial, then we have a tool with which we can do quite a bit of things amongst adolescents and adults in particular. Next slide, please, which presents the pipeline for TB preventive treatment. So this is treatment that is given to people who are infected and not yet diseased, right? And in the hope that it will stop them from progressing towards disease. So TPT is reserved for people at risk of developing TB, and often it is done after there is a confirmation of either significant exposure or else sexual infection with tests of TB infection. And you can see over here, I think there are over 40 studies that are in process. Some of them are testing out new regimens. So we hope to have one or two new regimens, even trials from one or two new regimens, even available next year, with which we can expand on the guidelines that we already have. And the next slide shows another important development that we hope to have in about 4 or 5 years' time, and this is the possibility of having long-acting technologies being used for TPT, in particular injectable products that can be used, and you can administer instead of bringing people for 1 month of daily treatment or 3 months of weekly treatment as TPT. It could be given in 1 or 2 doses, and that will overcome a lot of the issues that people have with, pill burden, needing to adhere to longish treatments, and also the side effects that are often associated. Okay, this slide takes us to the next part, which is about diagnostics. This is only about molecular diagnostics. You see there is a huge pipeline over here that has been developing over years. So it is very exciting times, of course, in diagnostics and many other areas of research and innovation in TB. And the next slide is just showing sort of the magnitude of the pipeline, about 100 products there, amongst which new biomarker-based point-of-care tests, other near POC products, POC with urine-based lateral flow tests, et cetera, et cetera. So there's a lot of products that are coming up. I can focus maybe a little bit on the next slide on the computer-aided detection of TB. So this is a technology that uses AI sort of machine learning algorithms to interpret chest X-rays in the absence of human readers, giving results for the screening use case, right? And interpreting the X-ray for consideration whether there is follow-up later on to send the patient to confirmatory testing or not. It's a technology that we have assessed as WHO about 5 years ago, so we've had this recommendation in place since that time, and it is, I think, it has been a very important recommendation. It's been used as a flagship as well for other AI products. Since then, we can go to the next slide. We have seen an expansion in the sort of range of different CAD products. There were 3 products on the market at the time. Now we have like 20 or more, and also expanding use cases for children and for diseases other than TB, which are, I think, important developments, some of which we will be assessing this year in a guideline group. Next slide, please. We can see some other fast movers in the space of AI-enabled technologies. You see the digital stethoscopes here, which can interpret sound. Likewise, applications on mobile phones that can interpret cough quality and cough signatures. And finally, the point-of-care ultrasound for analyses of chest lesions. Next slide, please. Okay, so the last part I wanted to mention is about treatment. So treatment, again, in the last 10 years, there has been a whole revolution in the treatment, particularly the treatment for multi-drug resistant TB, with the expanded use of new drugs, particularly bedaquiline and pretomanid, and the combination of these drugs in different regimens. So we have now the regimen that we used to recommend only a few years ago, which is the 18-20 month regimen, is the last resort regimen, as you see in this slide. And we have 6-month regimens with a much better tolerability profile as the first option that can be offered to patients. There are other options that can be given for children pregnancy, for instance, in the absence of or insufficiency of data that are yet available for the 6-month regimen. And then there are also the 9-month regimen options with different drug combinations. So in terms of TB treatment, so there are about 29 drugs that are currently in different phases of trials. So it's a great increase, right, from about 10 years ago, where we only had 8 drugs, 18 new chemical entities being tested for both rifampicin susceptible and rifampicin resistant TB. We look forward towards a prospect where we can give treatments that are pan-TB sort of that can be given regardless of whether the person is rifampicin resistant or susceptible. And also the advent of, if you permit, the advent of long-acting technologies in this space. This could also be a game breaker for TB treatment, because again, 6 months treatment is still long. It's still something that has a significant burden of treatment. So we look forward that we'll have injectables to also enter into this space, only as hybrid regimens, or else as totally injectable sort of treatment. And there are a number of drugs like bedaquiline and sorfaquiline, for instance, which can be also bear promise for TPT, but also for treatment, as well as these other drugs that you see here that lend themselves more easily for long-acting formulations. Next slide, please. The last thing associated with treatment is about the use of these digital adherence technologies. Right now, AI tools are also entering into this space in order to interpret the person's ingestion of treatment, and like that allow the treatment and reduce the amount of labor needed for constant patient support from a healthcare worker. So this is also another important, I think, technology that can be used to assess and help patients and complete their treatment. Okay, and finally, I just wanted to conclude. I hope that with this next slide, you can appreciate that TB remains a major challenge. The epidemic is receding very slowly, but we still need new tools and new energy in order to get where we want. We really are living through exciting times at this point in time in TB research and development, despite the fact that we have always some bad news on the horizon these days. We need more evidence from different settings and from different use cases to strengthen our guidance. So this is important, because the amount of tools that are coming in and the combination of different tools also present some important possibility for synergy. So it's important that we have experience documented from this. And of course, we value hugely our partnership with many different stakeholders so that we can get the tools as fast as possible to the people who need them. And with that, I want once more to thank very much Pat for inviting WHO to this, and the many people who provided the material that I had the privilege to present to you. Over.
Thanks so much, Dennis. And it was like a perfect whistle stop. You covered all of the essential pieces in terms of new products, where we are currently with the TB epidemic. And I just really want to echo your point around what an exciting time this is, because I think we've never seen as many options for treatment, for shortened prevention, and certainly in terms of vaccine candidates, but also the ability to really transform the way in which case finding and diagnosis happens, really making it a lot simpler through communities, through primary healthcare. But that means there's a lot to do. There's a lot to do in terms of understanding adoption in the country, the regulatory side, delivery, financing. So really grateful for your framing and all of the work that you're leading at WHO to ensure we have good guidelines and that countries are ready. I want to note that Dennis will need to leave at the top of the hour. So if you have questions for him, please make sure to post them soon. Thank you. All right, we're going to now move to the next part of the webinar, which are spotlights on person-centered introduction and scale of TB innovation. So looking at a little bit at the how to ensure more rapid adoption. So we'll hear from 3 speakers who are going to focus on diagnostic development, speaking again to how we are hopefully simplifying and increasing access to diagnoses and through better case finding. Also, we'll hear from an approach looking at decentralized access to TB services in Ukraine and also the use of CAD, which Dennis spoke to, as well as a systems strengthening approach for community-driven TB response in Kenya. So really some interesting examples. So we'll start first with Dr. David Boyle, who is the technical director for the Diagnostics program, is a extraordinary scientist who was focused for many decades on developing and advancing high impact and affordable and easy to use diagnostic tools and technologies. He has more than 20 years of experience and has spent a lot of those years in looking at TB and really how to transform how diagnosis happens across a number of different analytes, looking at everything from sputum to urine and so on. So with that, I'll turn to Dr. David Boyle to give us a presentation on the need for improved access to high quality TB diagnostic tools. Over to you, David.
Great. Thank you, Kim. And next slide, please. And I'd just like to start by setting the context for how TB diagnostics have evolved. This slide draws the Unity TB diagnostics pipeline figure that Madhukar and I used. And here the pipeline looked really promising with many molecular technologies in development for central laboratories, decentralized labs, and near point of care settings. But however, despite this apparent breadth, the reality was quite narrow. During the 5 years leading up to 2017, only 2 platforms translated into molecular WHO recommended rapid diagnostics, the Expert MTB RIF and the LoopAmp MTBC from ICAN. And really what this did was it highlighted a persistent gap between the innovation in the pipeline and the successful translation into WHO policy and country uptake. And so since then, WHO has significantly evolved its diagnostic policy framework to support more product endorsements. And they did this by a couple of ways. The first one was, instead of focusing on individual products, they moved to class-based recommendations for low, moderate, and high complexity NATs, with automation or not. And this shift expanded the number of platforms and assays that can be recommended for TB detection and drug resistance testing. And in parallel with this, the WHO initiated a really quite major regulatory transition from the TB-based endorsements to WHO pre-qualification for TB molecular diagnostics. And what this did was it aligned the regulatory pathways used for other in vitro diagnostic tests with the TB. And this transition started in the 2020s, and during which time the PQ, the recommended assays were still available for procurement. And now, as of today, there's 7 recommended platforms, of which the Expert MTB RIF Ultra and the Cobas MTB assays have now also received WHO PQ. And interestingly, from this slide, one of the things I wanted to point out was MolBio is the only manufacturer who are not from a high-income country. And the Chinese products that were listed here, none of them advanced any further. And my next slides will talk to that more. But overall, as shown in Dennis's earlier slide, the TB landscape for diagnostics is now really more structured, a lot more diverse, and supported by clearer WHO policy and regulatory pathways. And within that slide, there were 28 NATs, including 4 new near point of care NATs from Chinese manufacturers. And at the bottom here, you'll see a final point is the GLI and WHO have just released a guidance document to help NTPs identify which molecular platforms are best suited for the TB testing within their country. Next slide, please. So in this slide, really this is highlighting that the COVID pandemic really drove a step change in near point of care automated NAT development. There was unprecedented public and private investments that incentivized manufacturers to develop molecular platforms that were fast, simple, portable, and suitable for decentralized use. And importantly, this platform acceleration was matched by specimen innovation and research focused on sampling methods better suited for near point of care testing for TB, in particular tongue swabs and later sputum swabs. These specimens typically are easier to collect, safer to handle, and more compatible with the decentralized workflows than with raw sputum. And again, recently, the WHO have released draft guidelines highlighting their utility for TB diagnosis at their point of care. So, allied to the first point about the near point of care molecular devices, PATH worked with FIND and the Gates Foundation and systematically assessed the COVID near point of care pipeline and took a large number of technologies and shortlisted them based on cost and performance claims, and then took a subset of these platforms to select for in-house analytical benchmarking. And here, these evaluations, they deliberately used laboratory staff, but also naive users, allowing the assessment not only of the analytical performance, but also the usability of these technologies in near point of care settings. And these findings were used to directly inform targeted investments from the foundation into the most promising platforms, not only for TB, but for other infectious diseases. And allied with that, the clinical evidence for tongue and sputum swabs for near point of care testing has continued to grow. The recent paper from Smart for TB and R2D2 in the New England Journal of Medicine was really nice, highlighting the performance of these two specimen types in comparison to sputum sample or culture. And Cepheid, MolBio, and Plus Life are all near point of care platforms that demonstrate good performance. And I'll note here, Plus Life as the newest technology, they actually are standing out because their costs are so effective in terms of price. It's around $3.60 a test, which is an increasingly important consideration given budget constraints currently faced by donors and programs. Next slide, please. So turning to, excuse me, global market entry and scale up, Plus Life represents the first Chinese manufacturer with a low complexity NAT for near point of care. And there's several other smaller Chinese companies now expressing an interest in WHO PQ for their technologies. The PQ system is important because it allows procurement by UN agencies in Global Fund eligible countries, but the PQ process is very different from China's national regulatory policy, particularly in the scale and complexity of multi-site clinical evaluations. And so many manufacturers there are still building familiarity with these requirements. So partly in response to this, the WHO PQ unit has been very active in offering additional training and technical engagement with manufacturers, and PATH and our partners Act IVD are working directly with specific Chinese manufacturers to help them navigate the PQ process, looking at dossier review, iterative revisions of that, and doing manufacturing audits, doing quality audits in their manufacturing sites. And so building on experiences like these with Plus Life and Hubo Biotechs and other group, we're preparing a set of tools that we will be transferring to the Global Health Innovation Initiative in Shanghai, and this will provide them with the materials for longer-term support of Chinese IVD manufacturers as they plan for global market entry and scale up via the WHO PQ for their TB diagnostic products. Next slide, please. So here I'm just shifting a wee bit to look at the biomarker-based IVDs for point of care use. And so liporabdomanam, or LAM, is still a leading candidate for a rapid non-sputum-based TB test. It's a glycolipid released by TB cells during disease and can be detected in urine and plasma, making it attractive as a point of care test. They're well suited for lateral flow strips. And one of the nice things is that they actually have the ability to detect both pulmonary and extrapulmonary TB. The only test endorsed by the WHO right now is restricted to a very narrow patient population, and it doesn't have sufficient sensitivity for broader use across much larger populations who are also at risk of TB. So as a result, there's been substantial efforts, and these are ongoing, to increase the sensitivity of the next generation TB LAM tests to meet the WHO target product profile requirements. And these include improved specimen collection, LAM concentration, better reagents that are high affinity, more sensitive detection technologies, and easier access to well-characterized clinical urine samples in the R&D phase. That's actually an important point. And then on the last slide, this just aligns with something that Dennis had noted about the integration of AI into what we're doing. And here, we're working with a small company called Monod Bio from the University of Washington, or a spin out, and they're using AI tools to develop antibody-like proteins. I'll stress here, they're proteins, they're not antibodies, and they're using AI to design and develop these proteins as both capture and detectors, and with the goal that they can either match or exceed antibody performance. And you can see here in the table that the best set of novel body has given us almost double the sensitivity of the best antibodies in use right now. But I'll hazard, as you can see below the samples, the N is 16, so it's very small. And so at the moment, we're working on a larger sample size to see if this improved sensitivity still exists. And so this is just one of the examples where there's promising new pathways to maybe meet the sensitivity requirements for these rapid low-cost TB-LAM diagnostics. And I'll stop there. Thank you.
Thanks, David. That was a fantastic review of where we are in the state of the science, the regulatory approval and availability of a range of TB diagnostics. It's really exciting and really appreciate you spanning TB, NPOC, all the way through to LAM. I now want to turn to, and before I turn to the next speaker, also just want to flag to Dennis and David, you have questions in the chat, so grateful if you can respond to those.
Yes, I'm typing.
Perfect, thank you. So now turning to Dr. Yulia Dudko. Dr. Dudko is a radiologist at the Chernihiv Regional Hospital in Ukraine, specializing in radiography, computed tomography, and mammography. She's actively involved in the implementation and optimization of picture archiving, communication system workflow, digital imaging processes, and the integration of AI-based tools for chest imaging analyses. She'll be presenting on decentralizing access to TB services through introduction of diagnostic and digital innovation. So over to you, Dr. Dudko.
Good day, everyone. Today I will talk about how we are decentralizing access to TB service through the introduction of diagnostic and digital innovations. This is not just a technical transformation. It's about bringing care close to people who need it most, especially in challenging and resource-limited settings. In Ukraine, access to TB diagnostic and treatment is still uneven. Vulnerable populations often remain outside the healthcare system, and people in remote or frontline territories face serious barriers. We also face a shortage of radiologists and X-ray technicians, which delays diagnosis. Late detection leads to continued transmission of the disease. The core issue is simple. TB services are still too far from the patient. For effective TB control, services must come to the patient, not the other way around. Next slide, please. We started with digital infrastructure. We implemented PACS, Picture Archiving and Communication System, which allow medical images to be stored and accessed remotely. This enables remote reading of X-rays, supporting facilities that lack specialists. We also introduced teleradiology, which directly addresses workforce shortages. These systems can be integrated with medical information system, creating a foundation for scaling. Next slide, please. However, digital tools alone are not enough. We also need to physically reach patients, and this is where mobile diagnostic come in. We deploy mobile X-ray units directly into communities, including hard-to-reach and vulnerable populations. This allows us to conduct screening and point of care even under wartime conditions and limited infrastructure. Mobile diagnostics significantly reduce barriers to access. We are no longer waiting for patients. We are finding them. Next slide, please. This slide shows what mobile diagnostics look like in practice. Mobile X-ray units allow teams to bring TB screening directly into communities instead of expecting people to travel to health facilities. This is especially important for hard-to-access and vulnerable groups, as well as for remote and frontline territories. In wartime conditions and with limited infrastructure, this approach helps maintain access to essential diagnostic services. Next slide, please. This is the central message of the decentralization approach. Diagnostics should come to the patient, not the other way around. When diagnostic services are closer to people, we reduce delays, detect TB earlier, and improve access to timely treatment. This principle connects all the solutions in this presentation: mobile diagnostic, digital infrastructure, teleradiology, and AI-supported screening. Next slide, please. The next innovation layer is artificial intelligence. AI tools can automatically analyze chest X-rays and detect changes characteristic of TB. This helps prioritize patients who need repeat follow-up and supports physicians working in range without enough specialists. AI is available for screening where speed, consistency, and large volumes of images are important. It is a support tool that helps clinicians make faster and better informed decisions. For these innovations to work, implementation must be structured. Medical staff need training, engagement, and confidence is using new tools. Results and measurable indicators should guide decision-making and demonstrate effectiveness. We should start small and scale-proof solutions, moving from pilot project to broad implementation only after results are clear. Finally, system integration is critical. Next slide, please. Ukraine has strong potential to scale this solution further. Key priorities include expanding mobile diagnosis, increasing the use of AI for TB screening, and developing telemedicine. Another important priority is integration across all levels of healthcare so that screening, diagnosis, referral, and treatment are connected. Next slide, please. Thank you for your attention.
Thank you so much, Dr. Dudko. It's really exciting to see all of the digital innovation that's being integrated and applied in Ukraine. Truly a role model. And I think you said that cannot deliver modern TB care without digitalizing systems and tools. And also really great points around, we need to make sure that the diagnostics are available where the people are, rather than, insisting that individuals come in where that's not possible. So thank you. It was really excellent. I want to turn now to Fred Ombati, who is the TB and Leprosy Coordinator with Nyamira County Department of Health Services in Kenya. Fred brings 15 years of experience in coordinating TB services and has a key role supporting technical implementation management at both health facility and the community level. So really is at the center of how TB services get delivered. Over to you, Fred, to speak to some of the really exciting work you're leading in Nyamira County.
Thank you very much. I appreciate. As you heard my name, in Kenya, in the year 2015-2016, we did a prevalence survey that informed much of the decisions that have helped us curb TB in Kenya, and most so in Nyamira County. So from the prevalence survey, we had missed 40% of the cases, whereby we detected we have 426 per 100,000. So majority of the people are at the age of 65 and above, whereas health-seeking behavior was a problem from the community because they were not coming to the health facility. And symptomatic screening was not enough. So we had to embrace new technologies. And 75% of the people who had TB had visited facilities but couldn't get diagnosed. And a quarter of them didn't have symptoms pointing towards TB. So as such, from that survey, it was realized that chest X-ray is an important tool in terms of screening for TB, and the use of WHO recommended molecular tests was good enough for TB detection. So in the next slide, next. Yeah, these are the demographics of Nyamira County, whereby we are here to take care of a population of 750,000 persons with 116 facilities, and the community units have covered all the county in terms of the coverage, that is 100%. However, we have 5 WHO recommended molecular testing and 12 X-ray sites as per now. In the next slide, so from that, a policy was developed and the planning was done. Through that strategic plan, which was tailor-made from the country's strategic plan, coordination and everything was anchored. And at the year 2025, there was a Community Health Strategy Act, which was enacted, whereas even the funding for the domestic resource mobilization, which was enabled by the revolving fund in terms of health and technologies, the Facility Improvement Act, which usually help in terms of running the facility to request for the resources that they can use in terms of health services in the facility. Next slide, please. So what happened was expansion from 10 intelligence, that is the computer diagnostics. And further, 2 more portable X-rays were procured and they were supplied to the county, which are now mobile and portable. As you can see from the picture on that slide, we are in the field and doing targeted screening using the card X-ray. So after the card X-ray, we take the samples, network them to the health facilities, now for testing using the Gene Expert and the TrueNut machine in the various sub-counties in our county. These patients are linked to the nearby facilities, and at the end, they are done follow-up by the community health promoters. As you can see in our next slide. So at the community level, the health promoters, the community health promoters, we engage them in terms of training for TB, from the diagnostic to management and follow-up, screening at household level, especially referral and linkages, whereby they refer clients to the health facility who are reviewed by the clinical team. So in 2024, the CHPs started reporting formally through a digital platform whereby it's called TB. TB is the TB platform whereby everyone is supposed to report so that we can get this data timely and accurately from the facilities and from the community level. So during these processes, the CHPs are always engaged in mobilization for outreaches. And in that regard, they usually have the hotspots. And these are where we go for the diagnosis at community level, as you saw in the previous slides. So currently in the year 2026, we started engaging again the CHPs in terms of TB prevention. When they go for screening and the patients who are asymptomatic, they are usually given TB preventive therapy and usually followed by the community health promoters, whereby we want them to embrace the community-led initiative in terms of TB control. So in our next slide, we want to integrate all services at facility level and community level through the ICHIS. ICHIS is the Electronic Community Health Information System, where the CHPs do the reporting, again, for all the other common ailments in the facility, in the community, sorry. So the healthcare workers can be able to see what the CHPs are doing at community level, and whereas at the management level, we are able to see what the CHPs are doing. So to maintain quality at the sub-county level in terms of coordination, we do mentorship and capacity building to address any emerging issues in the community and the other facilities. So the healthcare workers also are oriented in terms of TIP system, whereas we do the reporting and recording bit of it. So in the next slide, as we finish, so in the progression of identification, you can see from the slide how we have been able to increase the detection level in the facilities and the community. That is a slide that has both what the facility has done and the community. This was from the year 2020 when we had COVID. You can see from the year 2020, the cases have increased by use of technology and use of the community health promoters who are enabling us work towards elimination and control of TB. And just to mention, our success rate has gone good. Yeah. So in conclusion, as the last slide, on the last slide, yeah, it's good we engage the CHPs at the community level to reach the vulnerable, and the use of the card X-ray as recommended by the WHO. We do continuous capacity building of the healthcare providers and the community health promoters. Then we want to utilize the digital platforms in terms of reporting to strengthen the collaboration between the community, the facility, and to end TB by the year 2035. Thank you very much.
Thanks so much, Fred. It was really excellent to see all the work that's gone into making sure you're integrating all of the right technologies, but also really equipping the role of the community health promoters to be able to provide effective case finding, support TPT, and so much more. It'll be interesting as we're turning now to the panel discussion, to hear more from you on how the role that you think that the community health promoters can play in tongue swab sample collection with TB NPOC platforms like Plus Life, and supporting also awareness as vaccines are made available and hopefully good uptake. So just you can start thinking about that. All right, so with that, we will now turn to the panel discussion, really looking at, reflecting on lessons in introduction and integration of new TB products and approaches. We have 4 fantastic panelists, starting first with Dr. Madhukar. I'll introduce him in just a moment. Blessina Kumar, Fred Mbati, who you just heard from, and Farzana Muhib. So with that, we'll start first with you, Dr. Madhu. You're the inaugural chair of the Department of Global and Public Health at McGill University, School of Population and Global Health. Previously, you were the director of the McGill International TB Center. You were the inaugural editor-in-chief of the PLAS Global Public Health Journal. Have done extensive research across India, South Africa, are a tremendous advocate, scientist who's really pushing all of us to do better in the TB response and in much more. And you've also posted a number of research articles in the chat, which we really appreciate, including doing an analysis of the critical pathway of some of the new near point of care diagnostic technologies. So with that, there is, of course, so much momentum around many of these new TB products. From NPOC diagnostic platforms that can involve tongue swab sample collection to other novel screening tools. But as we framed at the very beginning, adoption really lags, particularly in low and middle income countries. So where do you see the current biggest bottlenecks in product introduction and scale? And really importantly, where do you see opportunities for country or regional-led initiatives and allies to help to get ahead of these bottlenecks. I can think about many bottlenecks that we can anticipate with TB mpox delivery, and certainly with vaccines.
Thank
Over.
you, Kim.
Yeah.
Really appreciate this opportunity. So the first thing I'll say is, yes, the TB field is known to be a slow adopter of new technologies, unlike HIV. But what I found fascinating in doing the critical path analysis in 9 countries and 1 region is that the way we handle gene expert, for example, it took a long, long time. That already shrunk by the time we came to TrueNat, right? By the time TrueNat came along, countries were able to accept and adopt it much faster. So what would have been 5, 6, 7 years with GeneXpert got shrunk to 2 to 3 years for TrueNat. Same thing with BPAL and BPAL-M. The speed at which BPAL and BPAL-M got adopted is unprecedented in the world of TB, right? Dramatic as opposed to other shorter regimens in the past. So I'm feeling a little optimistic that the NPOC adoption curve will be even shorter than the TrueNat MolBio, but it won't happen on its own. We have to make it happen, all of us. So here are things that we learned from the critical path analysis in almost 10 countries. Asia is very different from Africa. Unfortunately, we haven't done it for South America, and I would be delighted if somebody wanted to do it. We can provide all of the materials on how to do it. Africa, for example, nothing really gets adopted in the continent unless there's a WHO approval or a PQ of some sort. It's almost like a absolute minimum first requirement, which means they are unable to get ahead of the WHO cycle. And even when there's a WHO policy, their adoption is often conditional on whether there's global fund money to pay for it, right? So it's WHO global policy and global funding. There's almost a requirement for many of them to move. South Africa may be an exception, but in general, that's how the continent works. Also, there are too many countries with relatively fragmented regulatory systems. So I'm happy now that they have the Africa Medicines Agency. So if there is a continental approval or harmonization of some sort, then I think the regulatory part will be a little easier. Otherwise, multiple regulatory approvals in these countries are often challenging. But regulation is also smoothened out if there is a WHO endorsement. Generally, WHO endorsement is taken seriously. So I think I'm loving the early adopter program by Global Fund, because whenever national TB programs are allowed to take the product and try it out, their excitement about it makes them adopt it faster. That's why all of us, when we do trials of new technologies, if we can work with programs, then they are already primed when the WHO policy comes along, and they're much more likely to adopt, which is why South Africa is often ahead of the curve, because they are involved in the trials themselves, whether it's lenacapavir or whether it's BPAL-M or whatever. Since they've trialed it, they feel great ownership. Now, Asia, now, the India's doesn't need WHO approval necessarily. South Africa, I mean, China doesn't, Indonesia doesn't. So they are more about their own technologies. Okay. So for example, India says make in India products are important. China will use Chinese. Indonesia wants to have Indonesian products. So this is a completely different market that requires us to think very differently. For these countries, while WHO approval may not be required, they often want to do operational research themselves. And I get it. I mean, tongue swab is simply not something any of us are used to doing. You have to almost re-educate doctors. Doctors will push back at it, I'm promising you, because they get all rattled because they're not used to it, right? So we have to explain to them that it is not an inferior sample. In many situations, it's the only sample we can get. There's a lot of education that will be required. Otherwise, they will be the ones to resist it, and then that percolates downstream. So there's a lot of change management required, right? So yes, I see tongue swabs as a nice replacement for smear microscopy, but that smear microscopist will have to be comfortable in moving away from old technologies to something new. So a lot of change management. That is why these large countries, the Indias and the Indonesias, want to do their own operational research. That can take a year or two, then they adopt it. But when they do adopt it, they have the money to just blaze their way through it, right? So this is the how we should be thinking about it. Each segment of the market is different, and what levers we can pull or push depends on that. And I'm glad Blessy is here, pushing the community demand for better tools will be very important to kind of build the momentum from the ground up, even as we are doing all this regulatory harmonization, technical assistance for Global Fund GC8 and all of that. Much of our effort is at the top level, but there isn't a lot of bottom-up ground advocacy like Lenacapavir, where everybody's demanding it, right? Where is a similar demand for a near point of care test? I'm not seeing it yet. We need to create it, which means they need to be supported. Thank you.
Yeah, that's excellent, Madhu, and really appreciate you framing the differentiation between Africa and Asia, different approaches, which are seen quite distinctly, but with a different scenario now, as you spoke to, with a collapsing time frame across innovation adoption in TB, which is really exciting, and with a lot of enablement that's happening across many actors, including with WHO speeding the guidelines, including for tongue swab sample collection, for the early adopter financing from the Global Fund, and some good community engagement, but really very good point though around not enough push from the community at the community local and national level to demand what is needed for the TB response. So with that, I'll be turning to Blessina next. So Blessina Kumar is the CEO for the Global Coalition of TB Advocates, and really works at that divide between communities, practitioners, and science through grassroots literacy and at the same time high-level policy engagement. She plays an active role in building capacity of TB communities and advocating for their inclusion in decision-making bodies. So, with the point that Madhu made, and with the work that you do, what do you believe really needs to be done moving forward in terms of true and meaningful partnership with communities from the very beginning, from R&D, research and development, all the way through to planning for delivery of key TB products within countries? What's working right now, but really what further needs to be done, and what allyship do you need from those on this call and the community working in TB overall? So over to you.
Thank you so much, Kim, and thank you for organizing this very much needed webinar. So like we've been hearing, there's been a lot of developments in the TB innovations. There are so many amazing new tools that are being developed, and I do feel it is a good time for TB. But we also need to understand that TB is not just a medical, but also very much a social problem, needing solutions that go beyond the medical. So when we look at meaningful engagement of people affected by TB, we need to consider an extremely important reality. No amount of new technology innovations will work if our systems are not set right. We cannot think of fitting in new innovations, state-of-the-art technologies into a crumbling systems, especially in high-burden countries. So an integral part of strengthening this system is about meaningful engagement of people affected by TB. For this to become a reality, I want to highlight 4 main points. First is building the capacity of communities. The TB-affected communities have extremely valuable lived experience of going through the TB journey with all its challenges. So when they know about the disease, the innovations, understand the guidelines, they are better able to point out the problems with the innovations as well as support the rollout. So in the past 20 years that GCTA has been around, we've trained over 1,200 TB survivors across the globe, in all the continents. And we have also helped establish 4 regional coalitions, which are now shaping and leading the response in the regions. Now, the second thing is meaningful engagement right from the start. So when it comes to new tools and innovations, communities seem to be thought of right at the end. When those amazing tools are not being used optimally, or when there is a need for demand generation. In reality, communities need to be at the decision and the discussion tables right from the start. So some best practice that we already are seeing, especially in the drug development, is the community advisory boards. These are extremely important, and I have been on several of them and continue to be on the Unite for TB consortium. And midway into the project, we are seeing very, very positive results from community engagement within the consortium. So not only is the consortium important, but also the trial site community advisory boards are very important. And we need similar mechanisms in the diagnostics and vaccine development as well. We have some civil society and community engagement in the vaccine arena, but we can do a much better job of it. Now, the third thing is understanding and accepting that communities are valuable partners and should be co-creators of the TB response. We have definitely come a long way from questions like, this is all very technical, what will communities do in this? To investing actually in affected communities like in India. But the challenge is if and when communities are used only for service delivery at the last mile. You know, the TB response really needs to be shaped and led by communities. You know, I was so happy when I heard the last year's slogan or the theme for the World AIDS Day. And it said, let communities lead. And this was shared by the executive director of UNAIDS and promoted on social media. We tried very hard for some version of this for TB, but realized that we do have a lot of work to do, and some heavy blocks need to be shaken and moved before this happens in the TB field. The fourth one is breaking down barriers that hinder access. Again, if there is no access to all these amazing tools, we've really lost the game even before we've started, or like Madhu said, it's going to take much, much longer. So in all our trainings, we've heard about two of the biggest barriers to access, and this has not changed in the past 20 years. One is lack of information, two is stigma. So no amount of amazing innovations will be of use if people who need them most or who need them are unable to or don't access them. Any new development has to consider this and ensure our innovations are not only addressing the medical problem, but also addressing the issues of access. For example, stigma. Our products need to really promote self-dignity and give ownership to people who are using them. And I think this is an area we could do a lot better in having people affected by TB as partners, as co-creators, hearing them, listening to them as the development process begins. And then when the product is ready, you won't have to actually start looking at demand generation, but it's already there. People will actually be asking for it. And this is something we really need to learn from the HIV world and go ahead with it. And this will need investment. All these 4 points will need investment. And so I really hope that we can get there quickly. Thank you so much.
Thanks so much, Blessina, for such excellent points, and really really being very clear around where the challenges are and what needs to happen, and in particular the investment and understanding that you have some good experience with TB therapeutics, with good community advisory boards, and with those advisory boards really being listened to and shaping the way in which trials are run, and I think you said it very diplomatically, but if I can, I think you're saying that there's much more that needs to be done in the diagnostic space and also in the TB vaccine space. And so I think we know in particular from what we've seen in HIV, and Madhu underscored what we see right now for lenacapavir, where you have strong community engagement from the beginning, then you will have strong advocates. And, you may also see very strong uptake. And so I think we need to apply that same theory of change to the TB response, which you've really clearly stated. So I think it'll be very important to understand how community engagement is happening as part of the TB clinical trials. And would love your further recommendations as we go on this webinar on how to make that happen for both diagnostics and for vaccines. But investment is key. Otherwise, addressing that literacy, knowledge and literacy piece around what is available among people who are affected by TB, and also stigma just won't happen in the way that it should. All right, so now speaking of vaccines, I would like to turn to our next panelist. Farzana is a program advisor for Path Center for Vaccine Innovation and Access. She brings 20 years of experience in a range of public health disciplines, including disease surveillance, epidemiology, vaccine demand forecasting, vaccine impact and cost effectiveness modeling, and country decision making for vaccine implementation. Farzana, it would be really great to hear more from you on what you think are the key considerations for TB vaccine introduction to ensure that vaccines complement existing TB prevention and care programs to enable greater reach and access. And I think also responding to the points that Blessina made around engagement from the very beginning with communities would be great. Thank you.
Thanks, and thank you so much for inviting me. I am new to the TB world, but not to vaccines, as you've seen, as you've heard. And so, when we think about vaccine introduction, perhaps I'll break it down into three distinct stages. And first is actually around decision making. So, we've learned a lot actually from malaria vaccine introduction in particular, and the importance of actually bringing together the TB program as well as the vaccine or the immunization program together to have these very critical discussions around the role of the vaccine versus the existing interventions that are being used to prevent and control a disease. And so I do think that for TB, that is going to be essential. We know that there are multiple vaccines that may have multiple use cases. And so those conversations will always need to be ongoing. But establishing some sort of framework between these two, let's say, government entities within a country is going to be key. To address actually one of the things that, I've been struck by and really heartened by, I would say, is the role of communities as well as civil society organizations in TB prevention and control. Well, I think we try in vaccines, but I think you all do that really, really well. And so I would like to also say that when we're thinking about decision making, we've got to figure out what is that role of CSOs or communities. Where do they lean in? We have very established mechanisms for decision making for vaccines that are necessary due to the fact that they are biologics, and so. But that doesn't mean that there shouldn't be a community voice. And I do think that we need to understand what that community voice, where that community voice comes in, and how it can be integrated. And I would say, especially when we're thinking about, the populations that might need to be vaccinated first, or maybe prioritize perhaps. So, I do see in decision making, it's that partnership, establishing a framework of partnership between these two very distinct programs that don't often get a chance to interact with one another, and then finding a voice for communities and civil society organizations. When we get to, let's say, vaccine introduction, I think this is where, again, it is going to be incredibly important that we have training for healthcare workers that are not just immunization, not just in the immunization program, but also in the TB program, as well as others, to really understand what the role of the vaccine would be and how it actually complements existing prevention and control interventions. And so, again, it is about training healthcare workers, but then again, and as Blessy said, engaging with communities as well as civil society organizations to build those bridges between communities so that they can also give accurate information. We, as everyone knows, vaccine misinformation can have a lot of negative consequences, not only for the vaccine that they are about, and bringing in like our experience with COVID-19 vaccines, but then potentially have a backlash on routine immunization. And so it's going to be incredibly important that accurate information is shared, and that accurate information is being heard by multiple by the community, by those most affected, but from multiple stakeholders. And so that is not a small feat. And then finally, as we're thinking about routine introduction or ongoing immunization, again, it is all about communication and ensuring that we don't just do social mobilization or advocacy and communication at the introduction space, but continue to do that so that we can sustain vaccine coverage as well as sustain the use of those existing interventions. And so, ultimately, it really is about communication. And that is how we will be able to, I think, have a vaccine successfully integrated into an existing TB program, as well as obviously into the immunization program itself. So I'll stop there. Thanks so much.
Thanks, Farzana. So yeah, clearly from your long expertise in vaccine introduction, we need to prepare. We need to, not underestimate the challenges that are ahead of us. And that includes going far beyond the traditional stakeholders, EPI programs in countries, and very much, as you underscored, working in partnership with community leaders and, of course, the NTPs and more. All right, we're going to turn now to our final panelist, Fred. So, Fred, thinking about the work that you've been doing in the TB response in Niamey County, be interesting to hear your reflections about how things have changed over the past, 5 to 10 years, and in particular, how things have changed in the health system and how integration of TB services into community health systems can contribute to stronger TB prevention and care going forward. And yeah, do you think that tongue swab sample collection would be feasible for community health promoters in Kenya? Over to you. Thank you.
Thank you very much, and much appreciation. For the community-led initiatives, I think from the prevalence survey, after the prevalence survey, much of the information was done through the main media houses like the television, radios, from the sampling technique, how it was done. So the community started being involved from the word go during the prevalence survey. And when the results came out, they had also to be informed about their results in that particular. So that informed the importance of involving the community health promoters and the community at large. Some of the information was cascaded down in the local language, whereby the communities could understand. Use of IEC materials like the cough, signs and symptoms of TB, which were posted to the lower levels of administration, like the chief's offices where people visit for various services, at the health facility level, dispensaries and all facilities. So these also informed the decentralization of services to the lower levels, the dispensaries, which are the level 2, initially which were not involved in TB care, especially for the government facilities. Also, this led to the public-private partnership when the facilities were able to be told, like, majority of the patients visit your facilities, but they go home and as being detected with TB. So the private facilities were brought on board. Again, most of the partners now came up with a training module for CHPs in terms of tuberculosis. So in that training module, most of us were involved and the information was disseminated. So we started seeing the cases being referred. However, there are those who couldn't come to the health facilities. So we had to go to them. You cannot go to our community with an empty hand. That is how the innovations now came, with the use of the digital x-rays and the card x-rays, whereby diagnosis could be done. You could even explain to the patient where the abnormalities are. This is a normal x-ray. This is where you can see the pathology. Whatever is happening in your lungs is what you can be able to visualize in the card x-ray. So at the end of it, they embraced it. And wherever we call for an outreach or the community calls for an outreach, we avail ourselves there, do the screening as healthcare providers, and those who are presumptive are tested. At the end of it, we have a rider, sample rider using the motorbikes, who links the samples to the nearest hub for testing, GeneXpert mostly, or the TrueNut. Samples are processed, and those who are bacteriologically confirmed, at the end of it, we involve the CHPs in terms of contact tracing, so that we can go back to that homestead and be able to screen further now at the household level to see if there are family members who had been affected or infected with the bacilli. Yeah, thank you. I hope I've answered.
Thanks so much, Fred. Really appreciate you further describing the role of the community health promoters and the way in which you're just decentralizing and making access to TB services so much easier as part of the overall primary healthcare reforms in Kenya. So with that, I wanted to see if there are any questions from the audience for our four stellar panelists. I do see that there was one comment/question which was put in the chat, really just around the stigma question. And, as we think about these new innovative products, to what degree will they actually be made available if stigma persists, and particularly as we're looking at integration into primary healthcare. So, we have TB clinicians who have been trained for many years, are part of the NTP system, but those systems are now, right, we're evolving. And so, what more needs to be done to ensure that the general practitioners, the staff at primary healthcare, are not stigmatizing individuals who need to be diagnosed and who are under treatment or TPT. So over to any of the panelists to respond to that question.
I can try and answer that in the interest of time. Thanks, Swati, for that question. Yes, very true. What we find is that many of the doctors, TB is not the first thing that comes to mind. And when it comes to mind, they're really ill-equipped to deal with the person who's sitting in front of them. And if you look at it from the community side, many of the TB survivors tell us that the most stigma happens within healthcare settings. So I think it needs to be done, stigma mitigation or stigma reduction needs to be done from both sides. And for that, you need an understanding of stigma, the causes of stigma, and what you can do. I think that is where we are, trying to say that let's go beyond the medical. And look at barriers that are hindering people accessing the amazing tools that are coming up. And I think it should be mandatory for all healthcare workers, starting from clinicians to everyone, to have a training on stigma, especially around TB. Thank you.
That's an excellent recommendation. I can see that applying for many different healthcare areas for primary healthcare providers, not just TB, but HIV and others. Are there any other contributions or thoughts around that question? So, Madhu, I wasn't sure if you were jumping in or not. No, okay. So, I mean, I think a separate question that I saw in the Q&A was really around the promise of some of the near point of care diagnostic platforms to not only be useful for TB, but also for other diseases. And so I'd be curious to hear your thoughts on, what does that mean as we think about strategic placement for near point of care diagnostic platforms? What does that mean in terms of collaboration more broadly, vertically with TB program, but also with, other disease areas and primary health care? So I'd be curious to hear your thoughts on, is that what we should be trying to do? And if so, how do we get there? And what might some of the challenges be?
My hunch says that right now it's the TB community that's excited about Plus Life and near point of care. So we will be the ones to push it the most into the health system. And then eventually people start asking, okay, it's in the primary care, it's in the PHC. Can we use it for malaria? Can we use it for something else? And I think I'm okay with that because somebody needs to drive it. If we say the health system will take it up and integrate it right from the get-go, it might take years, and it may not happen. So in some ways, some disease area has to be at the leading edge, just like HIV is the leading edge for many things, and then we catch on to it. In the case of near point of care and tongue swab, I think we are the cutting edge, and we will be the ones to push it, and then we can say what else can be done with it. Yes, it's a promise that it is a genuinely multi-disease platform, but it would need to be demonstrated effectively in a health system for people to get excited about it. So at least for the first year or so, I think it'll be primarily TB that will be driving this ship. And I think that's fine. It has to happen. It may not happen in an ideal manner, but I think it'll happen faster than we've done with other products.
Yeah, yeah. So yes, TB is the accelerant, and it's really the necessary accelerant. And then let's see where there's opportunities then to integrate across other diseases for more integrated platforms. Any other responses on that question? If not, I see a question here on really any updates on latent TB and where we are with addressing latent TB.
I think not much progress on diagnostics, unfortunately, and none of these products can really help us identify who's at greatest risk of progressing. But the greatest excitement is just continuing to shorten the regimen, right? So 1 HP, and if we can get long-acting injectables to a single shot prevention, that I think would be where we would probably aim for. Unless biomarker research really is able to tell us this is the small group of people that we need to be worried about, then everything suddenly becomes easier because the numbers collapse into a manageable number. But for now, we are using a fairly blunt tool instrument, but it's the treatment shortening where the most exciting work has happened, which is very good.
Mm-hmm. Mm-hmm. Yeah, thank you for that. Um,
If I could just also add, the M72ASO1E product is actually, testing the vaccine in IGRA positives. So, maybe another tool, that could become available, for latent TB. But, of course, we don't know yet.
Yes, yeah, Farzana, thank you for flagging that. Yeah, absolutely, very important point, and we'll see. Yes, as the evidence emerges. Last question, and then we'll turn to the call to action. This is around just cost. You know, what can be done to just balance between the cost of new products and the finances that are available?
I'm happy to take a shot at it. To me, the most exciting thing in the last few years, and I think David mentioned this in his talk as well, about 10, 15 years ago, all the products that we were excited about were all made in the global north, right? From Europe, from US and whatever. And we had to stand on our head to make it work, to make it affordable, to make it implementable. But the products that we are excited about now are all made in the global south, right? So the Plus Lives, the Who Else, the Malbios, the Serum Institute's skin test, right? There's a lot happening in this space. And I feel like that we've reached a tipping point where it will be the global south made products that would be the next wave. Already many of the drugs are made in India, right? India is already the drug manufacturer. And I think even if the vaccine works, I bet you it would have to be manufactured in a country like India to make it affordable for high income, high burden countries. So I think this is a good sign, and that's why its Plus Life is $3.6. Imagine if it was a Western company, they simply will not understand this model, or they will not believe that the products like these should be made available. So I am posting in the chat box a piece that we published in DevX on why Global South manufactured innovations are critical for the next wave of TB. And we've already visibly seen this happen. That is where all the AI products are coming from the Global South. I see enormous potential for Global South to be the innovator and manufacturer.
Such excellent points, Madhu. Yeah, absolutely. It's so exciting to see all of the manufacturing that's happening across Africa, Asia, and elsewhere. Farzana, over to you. Just really briefly. We'll turn next to Blessina.
Sure. So when we think about cost of an intervention, regardless of if it's vaccines or diagnostics, et cetera, treatment, of course, the cost or the price, let's be very clear. It's about price of the vaccine or the interventions is important when countries are thinking about introducing a vaccine and scaling that up, or introducing an intervention and scaling that up. But I think we also need to keep in mind the human side of that as well, right? Dennis mentioned, these infections can be what is the word? Blanking on the English word right now. Sorry about that. But catastrophic, that's the word. These infections are catastrophic to families. And so, really thinking about cost effectiveness, not only from a societal point of view, is incredibly important as we think about every one of these interventions and really understanding the true impact that these interventions have beyond saving lives, saving lives. In some cases, actually, you're saving a whole family. So really like changing that paradigm and thinking about it that way. So
yeah. Thanks for making that point, Farzana. Now I'd like to turn to Blessina, who's going to voice over a call to action based on everything you've heard as part of this session. So over to you, Blessina.
Thank you so much, Kim. Before I go to the call for action, I just want to say that meaningful community engagement is possible. And I want to very quickly share two examples. One is on building capacity of communities. We have a great ally in Madhu here who has proactively, at every summer institute that McGill has reached out to communities, TB survivors, encouraged them to come and put resources where his words are in giving, subsidies, in paying for some expenses, in taking care of people. I attended it maybe 10, 12 years ago, and it has lasted me and it has shaped the way I advocate. And every year this happens over and over again. So that is one best practice example. The second one is community advisory boards that I talked about. Midway into the Unite for TB consortium, 3.5 years, it's a 7-year project, maybe extended for another year. It wasn't without its challenges. We struggled. The 4 of us, 5 of us on the cab struggled. But midway, we are seeing lot of change, positive change. The recently held annual meeting had a full session on community engagement, and the leadership actually gave the space for trial site community advisory board members to come and present. I mean, how amazing is that? You know, you never hear about the trial sites. They came and shared successes and challenges. So I think we are heading towards the right way, but we still have a lot of work to do. So now coming to call to action. Now, there are many stakeholders in the TB response, right? The TB affected communities, donors, scientists, technical partners, implementers, developers, innovators, international NGOs, national NGOs, other civil society organizations, survivor networks, etc., etc. Now, we all have a role to play in the TB response in ending TB. Each of us have an important, valuable, and essential role in ending TB. And we all need to work together because, you know, not one is more important than the other, even though some of us might feel that way. I want to give an example of a car. Most of us own cars, drive cars. Now, the core purpose of this car, or any vehicle for that matter, is to move, to go from point A to point B. Now, everything in that vehicle, you know, works to make that happen. Now, each part can be made better, more efficient, smoother, cost-effective, but the core purpose does not change. It remains the same, of moving from A to B. So in the same way, our TB response, you know, of finding people at risk for TB, getting the right diagnosis early, initiating treatment early, curing, and also supporting people to get back to life as before TB should remain our core purpose. That cannot change. You know, everything else around it, the amazing new tools, innovations will keep developing. But if we forget the core purpose, that won't lead us anywhere. So let's keep that core purpose in mind of someone with TB getting cured, getting back on track. And we need to work together to make this a reality for each and every person with TB. And Dennis in his presentation talked about the incidence. It's in millions, 11 million. So think of each of those people who need to get better, and that all of us, not just on this webinar, but all over the world, who have a role to play to make that a reality. So the call to action here to everyone that I mentioned, all the stakeholders, is to remember the core purpose of the person getting better and getting back to life as it was before, and making sure that everything that is needed to make that happen works like a well-oiled machine. Even if one of us don't do it, the vehicle will stall. So let's come together, make a renewed commitment that we will make this happen, at least in our lifetime, if not by 2030, but work towards making this a reality, because people are dying every day from a disease that can be diagnosed, that can be treated, where people can be cured. So let's join hands to make our dream of ending TB in the near future a reality for everyone, especially for those affected by TB. Thank you very much.
Thank you so much, Blessina, for the very powerful reminder of why this work is being done. It's all about humane, high-quality care for people who are affected by and living with TB, and that we all need to really work together effectively to make sure that that happens. It's not about the product, it's about the people. I really want to thank you. I want to thank Dennis, David, Yulia, Fred, Madhu, and Farzana. Thank you for your passion. Thank you for your wisdom and for joining us today. We very much appreciate it. We wish you well in all of the phenomenal work you're doing in the TB response. So thank you. And thank you to all of the participants today.
Thank you.
Thank you. Bye.
Thank you. Bye.